If I can have your attention, please. My name is Bill Knoll. I'm the president of the Central New York Health Systems Agency, and I'd like to welcome you to our community forum for the proposed merger of Upstate Medical Center and Community General Hospital. I want to thank those in attendance. This is a hard room to sit in the back of, isn't it? So I saw the back fill up, but we have filled the room, and I think the turnout is indicative of the interest in and the importance of the topic and the need for this forum to solicit community input. This forum is being co-sponsored by the Central New York Health Systems Agency and the Health Advancement Collaborative of Central New York, HACNY. Our two organizations are working together to develop a sustainable health planning model for Central New York. And I'd like to introduce our HACNY president, Eric Hunt. Eric. And we also have Tim Bobo, our executive director of the HSA, and Nancy Smith, our HACNY consultant. I want to thank and introduce John Eberly, the vice president of the Community Foundation of Central New York, and express our gratitude to the foundation for their hospitality in providing us with this new home for this event. And John?
Good evening, everyone. On behalf of Peter Dunn, our board and our staff, we want to welcome you to the CNY Philanthropy Center. This is actually the realization of a dream for us to be able to host events of this kind. So we're just so glad you're here, and I hope none of you are a fire marshal, because I think we've exceeded our, anyways. I hope you have a good evening tonight, and we're just so thankful that we can host this, and great work. Thank you.
Thank you, John. I just want to mention that the program for tonight, we are going to have presentations, as I mentioned, by Dr. McCabe and by Tom Quinn, and then we're going to have public comment, and we will be following some time frames for the public comment. We had a sign-up sheet, and those who speak will be held to a 3 to 4 minute time limit. After 4 minutes, you will be asked to wrap up your remarks in the essence of time. So without further ado, I'd like to introduce the administrator, president and CEO of Community General Hospital, Tom Quinn, who's going to start the evening off. Tom?
Thank you, Bill. Can you hear me? Am I transmitting yet? Okay. I'm going to speak for 5 or 6 minutes, and then I'm going to turn it over to Dr. McCabe. When we look upstate, we see that over the last 20 years there have been a number of hospital consolidations, especially in the urban areas. These are some of them in Utica, Rochester, and Binghamton. A lot of the hospital consolidations in Syracuse took place in the 50s and the 60s, but we've sort of had this long lull. In recent years, there has been a lot of interest and indeed planning for hospital consolidation in Syracuse, and I highlight just a couple of the events. We've had the Lewin study in '96. There was a Healthcare Futures update to that in '98. There was another consulting engagement by Providence Health Partners for community organizations and hospitals in 2001. We know we had the Berger Commission report at the end of 2006, and there have been bilateral hospital discussions during this period of time. It appears we have an issue that we haven't been able to solve yet. My hospital, Community General, has been in the forefront of a number of these discussions. We were partners with Crouse Hospital during the Health Alliance in 1999. That broke up at the end of 2002. We closed 50 nursing home beds as part of the Berger Commission compliance in 2008. And in 2009, FTI Consulting, an outside planning organization that we contracted with, did a review of our strategic plan and recommended to our board of directors that we look for a strategic partner. We've done this in sort of a pretty public way. We've had discussions with Krause Hospital in latter 2009 and 2010. Those did not come to fruition, those discussions. And since June 2nd, I think, was the official date that we signed a confidentiality agreement, we've been in discussion with Upstate. This is our vision, and it dates from 2003, after we had left the Health Alliance. And I want to call your attention to two pieces of this, two features. We will be a high-performing acute care provider serving increasingly intensive patients, and we will be a trusted collaborator with those who share our mission. We knew, we felt, embedded in our plan in 2003 was the understanding that a consolidation among the Syracuse hospitals was inevitable sooner or later. And although we couldn't predict the future or know exactly when, we said that it was important for us to understand that a hospital was going to see sicker and sicker patients because of the outpatient shift in terms of reimbursement and technology, that we had to be a solid hospital and pay attention to quality and to our infrastructure, and that we had to be a trusted collaborator because we didn't know how the consolidation would shake out. We had to maintain good relationships with the other providers for that eventuality. And we have been high-performing, both in the investments we've made in our organization, whether it's the physical medicine and rehab, the Jim and Dee Dee Walsh Family Birth Center, surgical technologies, selective upgrades of our physical plant, some examples. And we've had good outcomes. We are among the leaders in town in making improvements in our potentially preventable complication rate. We have a readmission rate that is lower than our comparable hospitals for the same case mix index. We've made breakthroughs in infection control, in some cases reducing them to 0. And we've been noted by Excelis for Blue Distinction Centers, by Health Grades, by Consumer Reports, just examples that we've paid attention to the performance. And we've been a trusted collaborator, working through the Hospital Executive Council, sharing laboratory services, and working with others in the community because we knew we would need help, friends, and we would be part of the solution at the right time. This lists our current relationships with Upstate. We've had residency training forever. We've had the physical medicine contract. We have the same providers as Upstate for our acute rehab unit. We have the same providers for our emergency department. And even recently, we have expanded our hospitalist service. We have an exclusive provider arrangement for intensivists from Upstate, and we've expanded our cardiology coverage, and more are planned, even before we have a formal relationship. About a third of our medical staff has privileges at Upstate. What do we want from Upstate? These are our goals as adopted by the Board of Directors. We want to develop the assets of this hospital or this campus after the acquisition, consistent with, obviously, the purposes and goals of the SUNY system and its Upstate Medical University for the benefit of the community. We want to further the mission and function that was consistent with Community General Hospital in our traditional service area, inpatient care, emergency care, outpatient care. We want to make sure that we employ to the best advantage the assets that we have in place. And it's number one, our workforce, it's our skilled medical staff, and it's our property, plant, and equipment in which we've invested for all these decades. We're looking for a plan for the appropriate discharge of the liabilities after the acquisition, and we're looking for to continued involvement of the volunteers, board members, volunteers, auxilians that we have already engaged. Some advantages we see of the combination. We maintain the clinical access in our traditional service area as a hospital. We expand specialty coverage for patients, and we've already seen some early indications of that, as I mentioned, through intensivists and cardiology. We're looking for access to capital for reinvestment in the physical plant, which is in good shape, but we don't have the capital right now to invest as we need in the future. You may have read Jim Mulder's story in the Post-Standard recently about a recent downgrade of our credit rating from Moody's, and they said the hospital's done a good job of funding its depreciation, but looking forward, it's got real challenges in how it gets access to capital for what's needed for the future. We're looking for resources that will help us in medical staff development. We've had doctors who have left private practice, have left the state. We can't replace them, and some of our groups can't replace them. That's not a good trend for the long term, especially as we face increasing doctor shortages. We think this plan helps right-size Central New York hospitals. We think it will help spread fixed costs over a larger operating base. It will, over time, transform our community hospital from being locally focused, 85% of our patients are from Onondaga County right now, to a much more part of a regional system. We still see our campus, our assets, functioning as a community hospital and not as a tertiary center, but really much more integrally involved with the academic tertiary center. And we think this helps us prepare for healthcare reform. That's a quick overview of where we've come from and why we are where we are. I'd like to turn it over to Dr. McCabe. Forward, backward, point.
Thanks. Well, I want to start by thanking Hackney and HSA for hosting us. I think this, for me, is, and I think for Tom, kind of a continued dialogue in a yet unfinished story. We're getting farther and farther every day, but we're not to the finish line yet. I also thank the Community Foundation for having us and hosting us tonight. It's an organization I would guess many of the organizations here represented have been touched by dollars from the Community Foundation, so they're an important resource, and it's nice to be here. This is about planning and trying to improve patient care and efficiency over time. And I thought I'd start with a little historical perspective to say all the planning and changes in Syracuse and healthcare over the years, we made a lot of improvements, but we still have some ways to go. Some things are the same. And I start with, this is the report of the House and Hospital of the Good Shepherd, the report to the house mother in 1880. And was sent to me by Jim Abbott. But it's interesting. They say here they had 6,755 bed days in 1880, and the average length of stay was 58 days. So we've improved a lot. On the other hand, they say that the average cost per care per day was just a fraction over 58 cents. So I guess we got in the wrong direction. But then they also say that one of the reasons the length of stay was so long was because there were chronic patients who continued in the hospital throughout the year because no other place can be found for them. So I guess even then they had nursing home problems. So we still have a ways to go. So thanks to Jim Abbott for that. I'll take you through about a dozen slides and give you a sense of where we are. And again, I'd ask people to consider this as it's still a work in progress. We're farther along than the last time I've spoken with many of you individually or collectively, and there's still more room to go. I'm going to start with Upstate Medical University, because it's important that people have a clean sense of what we are, and I'll start at the top. So the Upstate Medical University, we say it's not a hospital acquiring a hospital, it's a university hospital acquiring a hospital. And the university consists of the university hospital, 4 colleges, over 400 physician faculty, and it has an important education mission. We are state supported. We're run like a business, and we have a noble public mission that won't go away. That's important. We have a $1.2 billion budget, and we're the largest employer in Central New York. And interestingly, some people don't know this, but only a fraction of our support day to day comes from the state of New York. So on the hospital side, it's about 5% of this almost $700 million budget that we operate with. So we make money in town just like everybody else does. We earn it. And so hospital revenues support hospital expenses, and that's important. This is a complex slide that I'm going to spend 30 seconds on just to give you a visual of my sense of the Upstate Medical University health system and where does this creation and where does University Hospital fit. I talk about concentric circles, and you'll see they go all the way from Onondaga County, and if you come out here, it's the rest of the world, okay? But the middle is University Hospital. And in Syracuse, we provide primary and tertiary levels of care to patients close into our hospital. We do very much the same thing at some level that Krause and Community and St. Joe's do. As you move out a little farther, we provide higher end, more specialized services. Sometimes patients come to us. Sometimes we send doctors and students out to them. As you get farther and farther out, then we provide more and more specialized services that others inside these circles don't have. That's my concept of a big system. And as a big system, one of the goals that I think Tom already talked about is trying to link primary care, a community hospital, a university high-end, high-tech hospital together gives us a better system and a bigger platform to meet all of the needs in this very broad region. That's really the reason that we are looking at this creation. A few things about University Hospital. We run pretty much 90+% occupancy in our med-surg beds. This morning, like most mornings recently, I had 0 beds at the start of the day to put the next patient who needed to be admitted into. We're out of space. I can't build any more here. I don't have the grounds around me to build more. Our own plans, and all of us do strategic planning, said on our campus alone we needed 510 beds. We have 409. We need to expand our emergency department. It's stuffed and on diversion every day. We need to expand psychiatry services, and I think issues like what happened recently in Tucson make it clear that our mental health system in this country still needs some expansion and some improvement. There are current service lines that we do well, that we're asked to do more every day. We have regional demands and we have safety net functions, things like trauma care, burn care, pediatric care that others in the region can't or won't do. Tom and I have started with a set of principles from day one, and I think we've kept true to them. We've said this is an asset acquisition. It will become a single hospital with one provider number. It's our intent to maintain a full range of community hospital appropriate services. We're not closing down Community General Hospital. We've said that we want to maintain some identity and recognize the history of Community General Hospital, and it's our intent over time to invest resources into the Community General Hospital campus. We are committed to a single standard quality of care, and we're also committed to supporting both private and academic practice. We recognize that Community General Hospital's long history is with private physicians, not with academic teaching faculty, and we'll continue to keep that model in place. We've said we want to have an objective to maintain continuity and recognize the vast experience and quality of the workforce there. And we've said from the start that we're going to have what we hope will be viewed over time as a fair-minded approach to this activity. The things that we've been doing in the last 6 months, Tom mentioned some of them. We started with a confidentiality agreement. I showed you our principles. We went to the SUNY Board of Trustees, that is my hospital Board of Trustees, and asked for their endorsement. We've done due diligence, which is looking at, I think, close now to probably 300,000 pages of documents to be sure we know each other well. We've helped to meet some clinical and program needs that Tom talked about. We've had a financial engagement by PricewaterhouseCoopers to look at what combining models in different ways look like. We've worked on clinical programming and medical staff discussions. We've redesigned a potential set of bylaws that would integrate the 2 medical staffs together. We had a letter of intent. We're pretty close to an asset acquisition agreement, which if you bought real estate is the equivalent of the sales contract that you sign with your real estate agent. And we've started down the path of all of the approvals that will be required. Department of Budget, Department of Health, the Office of the State Controller, Attorney General's Office, SUNY, the Governor's Office of Employee Relations. And I could add some others, but there's a long list. So those are all underway. From the start, we've said the private practice of medicine will be the private practice of medicine there. We'll support it. We hope that through our actions, we'll enhance it. And I think things like our presence of hospitalists have already done that. We'll integrate where it makes sense. We'll recognize separateness where geography or history or business models mandate that we do that. We talk a lot, for instance, the orthopedic services there. Well, there's a big orthopedic service there. There's a big orthopedic service over here. Those will probably always stay separate because business and history will make them so, and it makes the most sense. We think we'll have a dynamic model that changes and meets patient needs over time. And we want to create teaching opportunities, not teaching mandates for both staff and for the physicians that are going to be at Community General Hospital. Part of our desire is to build a bigger platform to ensure that we can train the medical students and professionals, nurses, PAs, nurse anesthetists that will be needed to meet future needs in the region. What do we view as some of the potential impacts and benefits? Well, we think more efficient use of existing resources. There will be some economies of scale. There will be some construction costs that you might avoid. If I wanted to build another 100 beds on my campus, it would be incredibly expensive or near impossible. We think clinical services, we'd love to have a better movement of patients so we could prevent ED diversion. We want to preserve the availability of physician practice in that geographic region, meet more regional responsiveness for the patients that at my institution we turn away every day as I don't have the bed space to put them there, help us educate new professionals, and have a geographic presence for hospital care on the west and the south side of the city. And lastly, we think there is an economic development both in the short term and the long term. The renovations that will be required over time as we commit to infusion of capital into this new entity, maintaining the current workforce, and we believe over time growth of the workforce. People often ask me, what's this going to do to the other places in town? And so I put up 3 of our partners here, and I could expand it with our partners as we go out farther. We in Krause have many relationships. Our pediatric doctors respond and care for patients in their PICU. Our obstetrics department academically is based here. Their cardiologists send their patients to us for cardiac surgery. Those kinds of things are natural alliances and aren't going to change. The VA is in some ways our biggest partner, and we have many, many medical residents there. We share faculty. We share some programmatic things. And maybe a little less so, but certainly St. Joe's is also a site for clinical training and for sharing some services that we have that they don't have, they have that we don't have, like their family medicine training program. So some of these will continue unfettered. They have to, because it's what makes healthcare in the community go. Lastly, I'd touch on what we know and what we don't know. So we know there's a strong desire to make this work by the 2 institutions. We've not seen any obstacles from a due diligence point of view, and we think that looking at the finances that joining our 2 institutions makes sense, and that with clinical integration and stopping some of the duplication and enhancing services that we can further improve efficiency. We think that over time, the projected bed configuration is larger than the current staff beds and less than the current licensed beds. And I know that's a confusing thing because licensed beds in some ways are paper beds, and they relate to when hospitals had 3 and 4 bed wards and the like. So we can come back to that a little bit later. We think the bed alignment, there's the current beds, 409, 306, those are licensed beds. Our strategic planning is for 510, as I said. Today's occupancy this morning was almost 400 at University, 131 at Community. The principles that we're going to use to realign beds are right size for the total bed capacity, looking to meet regional needs, expanding services where appropriate, new initiatives such as adolescent psychiatry that we need, geographic availability, avoiding duplication, and at the end, probably removing some excess beds from the system. Things I don't know yet, some assets that Community has, we're still looking, do we want them or not? Final management structure, final service configurations, final labor model. We've looked at a range of labor models from all private, all public, some in between, and each one of those has differences in terms of cost and our ability to clinically integrate services. We, at the end of the day, need to avoid confusion at the bedside. We need to have groups of people who can work together philosophically and structurally. So we are in the final stages of determining that. And then lastly, I showed you some of the regulatory bodies that I need to go to, and we're not sure of their final response. The last slide is the timetable. We're looking for the asset acquisition agreement soon. We are continuing the regulatory discussions. We're continuing with our physician staffs in both places, clinical integration. The certificate of need application is underway. It will probably be submitted sometime in March. Labor plans, we think we'll have a full understanding of the impact of each of the models from clinical integration, from workforce, from cost soon. And we continue to have a target deal completion date of July 1 of 2011. That's when I say to Tom, he turns the keys over to me. Not really, but we'll have probably a 2-year period after that where we continue to work to wind certain things down, to start certain things up, and to have a full understanding of the integration. So in some ways, July 1 is the starting date, not the ending date. So with that, I'll stop, and we'll be happy to answer questions.
I'd like to thank our 2 CEOs, Dr. McCabe and Tom Quinn, for their presentation. We have a agenda outline that calls for public comment, some questions and discussions, and then a brief overview of the next steps. So the ground rules for the public comment are that people signed in, which people did, and to indicate if they wanted to speak. We've had 8 people indicate that they wanted to speak. We will limit their time to 3 to 4 minutes. It's optional whether you come to the podium or not. The time frames are not optional. You will adhere to the time frames. So we're going to call people in the order that they signed up. And Tim, call upon our first person for public comment.
First speaker, Ruth Heller from 1199.
Okay.
Hi, good evening, everybody. My name is Ruth Heller. I'm the area vice president for 1199 here in Syracuse. We represent healthcare workers. We have about 7,600 members in central New York. They work in hospitals, they work in nursing homes, they work in home care. We represent 900 workers at Community General Hospital. So we're here to comment on the potential acquisition. We think in order for the merger or acquisition to be successful, there's 3 things we need to keep in mind. It must be done in a way that preserves the community service mission of Community General Hospital, which we've heard mentioned. It should provide stability and fair treatment of the staff, which we've heard mentioned, and it should support the differences between the 2 hospitals. We think this would be the best way to allow our region to benefit from both types of hospitals. As everybody knows, and it's been pointed out, University Hospital is a large, teaching, high acuity, high-tech hospital that has the potential to expand its regional reach, but it is also a high-cost hospital. Community General Hospital should be preserved as a lower-cost, private sector, community-type hospital with a family atmosphere and independent physician practices. On the Community General and Upstate University Hospital merger website, under the frequently asked questions, it does state that the intention is to preserve the community hospital model at the CGH campus and to retain CGH's distinct identity. And we've heard that mentioned tonight. We want to make sure that the structures that come into place support that. We really think it's important that there need to be protocols and systems in place that will preserve and support Community General Hospital's separateness. The merger should also assure that workers will not be shifted from University Hospital to CGH or vice versa. We think this would be too disruptive for staff at both places and affect the quality of patient care. The hospitals have different cultures, and we shouldn't aim to make them the same. In fact, if you look around the country and do the research about other mergers that have succeeded or failed, one of the most common reasons why they've failed is because 2 hospitals have come together and they've tried to integrate and force 2 different cultures to be the same. The potential in this merger being successful is to say, we've got 2 different kinds of hospitals. Let's celebrate that. Let's make the best out of each instead of trying to force them to be more like each other. So we should learn from these failures around the country, start from the beginning by acknowledging the differences, establishing structures, protocols, and systems that keep those differences in place rather than forcing them to be the same. I also want to point out, and maybe goes without saying, it's not the time for increasing healthcare costs or adding staff to the state payroll. So it's also crucial to preserve what makes CGH a lower cost hospital than University Hospital. For example, with regard to length of stay, meaning the number of days on average that a patient stays in the hospital, in 2006, well, let me just say, they're both less than 58. So neither hospital has climbed to, what we had in 1880. But the average length of stay for CGH was 4.7, and for University Hospital was 6.6. Now, there's good reasons for this. It makes sense. It's a teaching hospital. It's a high acuity hospital. But again, it's more expensive, and I don't think we want to import that into Community General. The same with reimbursement rates. If you look at the Medicare reimbursement rates for the most commonly DRGs, diagnostic-related groups, you'll see that at University Hospital, it's $3,000 per discharge higher than Community General. Again, makes sense, teaching hospital, expensive technology. But we don't want to export that to Community General Hospital. To make the merger work, the capable and qualified CGH staff must want to stay, and the capable and qualified university hospital staff must want to stay. So we're advocating supporting what each set of staff is used to. An important piece of the merger depends on fair treatment of the nurses and other healthcare workers. It wouldn't be fair to transfer them to the New York State payroll because under civil service law, they would need to start as new employees, even though they may have 20, 25, 30 years of seniority at Community General. As new employees, they'd be the first laid off if New York State were to reduce staff at the merged hospitals. For these reasons, we recommend the concept being followed in the downstate merger between Downstate University Hospital, which is public sector, like up here, Upstate University Hospital, and Long Island College Hospital, which is also known as Litch, which is a private sector, smaller hospital. And in that situation, they're preserving the private sector aspects of Litch. The employees remain in a separate labor union, separate contract. They continue their wages, their benefits, their working conditions that they're used to. But the hospitals themselves will operate under one Article 28. So you kind of get the best of both worlds. You get a nice community, family atmosphere in one hospital, and you get the teaching possibilities and the academic reach of the larger hospital. So that's our pitch. Thanks.
Thank you.
Next, and I would ask speakers, if you have a copy of your comments, please leave that with us. And if anyone would like to submit written comments after the forum, we certainly will accept those. They should be forwarded to the Health Systems Agency or emailed, and the email address for the Health Systems Agency is cnyhsa@cnyhsa.com. Next speaker is Steve Infante. Steve Infante from Community General Hospital.
Good evening, everyone. I just wanted to speak as a community person, the large C, community, Syracuse community. I've been involved in community hospital for close to 25 years. I know I don't look that old, but I have been. And many of my board members, my fellow board members who are here and I've served with and been proud to serve with, have also been involved. Community hospital is just that, a community hospital. It started, the charter was that. Our forefathers, Tom is a history buff, and he's told me all the history of the 50s that led up to this. And we've always taken a position that community hospital is a community asset. All the studies that have been alluded to and Tom has put up on the board have indicated at some point in time that things had to change in this community. We took that as a board as a very serious charge, that our charge is to preserve that asset. We've gone through a lot to do that. We've tried twice with Krause, and see Paul over there, and we became friends, and foes at sometimes, but friends through this. We had an opportunity through a presentation from Upstate, and we as a board agonized over this as to what was the best course for our community asset for the Syracuse community. It wasn't an easy decision. John McCabe has made it a little easier because of all the things as he's presented. It helps preserve our community asset and the way that our board believes it should be preserved. So I would encourage everyone here to take it from that perspective. 25, 30 years, however long it's been, Burger Commission, no Burger Commission. It's still a community asset, and the best way to use this community asset is what we're trying to do with Upstate. Thank you.
Next is Ron Legault from the Hospital Executive Council.
A lot of what I've said has already been said factually, but I guess just to make a comment, the Hospital Executive Council is the planning organization for the 4 non-federal Syracuse hospitals, alphabetically. That's Community General, Krause, St. Joseph's Hospital Health Center, and University. The mission of our organization is to improve efficiency and outcomes in the healthcare system. I always kind of think about that in the paraphrase of the country music song that we were in favor of efficiency when efficiency wasn't cool. Now everyone's in favor of efficiency. But it's a meaningful item to us because those of you that work in the hospital system know that we produce a report that relates to efficiency every single business day. At the beginning of the day, John cited it, thank you, sir, in one of his slides. And we work to make efficiency real. The biggest manifestation of that has been our efforts on length of stay reduction, which during the past 10 years have supported the elimination of over 41,000 patient days in the system. It's an average daily census, an excess census of over 100 patients taken out of the system through improved efficiency. Down the road, we're looking at matching outcomes and efficiency by reducing inpatient complications and readmissions. And again, these are real projects. And we believe that context for efficiency and outcomes has really done a lot to pave the way for mergers and consolidations in the system. The inpatient system, kind of amazingly, only sustains an average daily census of about 1,000 patients a day. 70,000 discharges going through 1,000 a day, turning over throughout the year. And we believe this merger will help sustain that. Tom, no offense, you didn't mention it, but we also were the provider of the Lewin VHI study back in the 90s that set the standard for looking at bilateral consolidations as a way of trying to consolidate this system. And as the guys have pointed out here, it wasn't easy. We've had a number of joint ventures that have developed short of mergers between St. Joseph's and other hospitals. We've had 2 failed efforts between 2 of the hospitals, Community and Krause. We have an ongoing series of discussions that will continue between Krause and University. But in terms of a real merger, like what has occurred in other communities, it hasn't happened. And in the process of all of those things, we have exhausted all the alternatives, and the one that we really haven't explored that finally seems on the verge of bearing fruit is this one, Community and University. So from the HEC standpoint, and from the standpoints of efficiency and outcomes, we believe that this is a good fit. It's a good fit for the hospital system. It will serve the interests of the community, and our 4 hospitals endorse it, and we have endorsed it at the HEC level. Thanks.
Next, I'll call Mary Shirley.
Good evening. My name's Mary Shirley. I work at Community General Hospital. I'm a technician. I've been there 27 years. I believe the CGH should stay a private, non-for-profit hospital within the university hospital system. Because we as employees are forced to go into the university hospital system, people like myself will lose vacation time, my seniority, for bidding on jobs. So when there's a threat of 900 plus people in the state system that will lose jobs, what protection do any of us have? So I lose at least the last 27 years of my career time will be gone. I have a grandchild, I have family. I enjoy spending time with them like most everyone in this room. I have a mom who needs me to take her to her appointments. I won't be able to do that because I won't have any time on the books to be able to do that. I'll have to start a new pension plan. I'm 56 years old in April. I'll have to start a new pension plan, which I won't be vested in until after 10 years. You hear in the media all the time how the state is having such problems. Why would they want to take on 900 more employees so that they can be laid off? I say let's keep our private union, SEIU 1199, at Community General Hospital. This can work and has been proven with the downstate lunch model. Thank you.
Next speaker, David Salati.
Hi, everyone. Thanks for the opportunity to speak to you all tonight. I see a lot of familiar faces out there. I've known a lot of you for most of the 39 years that I've been an employee at Community Hospital. I, like Mary, am in the same pension bind. I just turned 55, so I had hoped to retire at 62 years old, but if this acquisition goes through, that doesn't seem to be in the cards for me. I'd like to put a little bit of a face to some of the employees that are standing in the back, because in the presentation, although it was very factual and I'm sure very accurate, it doesn't really say much to the heart of Community Hospital, to the people that made it what it is today. There's Chuck Braun that works with me in the engineering department. He's got 40 years here. There's John Shamati who works in the kitchen. There's Rick Kelly. There's Glenn Wagner. There's a whole host of people here that have as much at stake as anybody else in this audience. My daughter was born at Community Hospital. My grandchildren were born at Community Hospital. Most of us have had parents now that spent their last days at Community Hospital. So for us, it's much more personal than a screen with some overlays on it. It's very heart-wrenching for us. Most of the employees are really frightened that this is going to happen to them. They are concerned that they will lose what it took them so many years to earn. So I also would urge that consideration be given to them, that we maintain our union at SEIU 1199, and that we retain our seniority, more as in interest of fairness and to do what's right than what's contracted. So, thank you.
Next is Rosemary Glover.
Oh, my God. My name is Rosemary Glover. I'm 68 years old. I'm a widow. I have been a nurse since 1983 after doing many, many, many diverse other things in my life. I come to nursing, honestly. I have a mother and 3 sisters who are nurses, and a brother who is a medical technician, and a sister who taught at Johns Hopkins. I came to nursing maybe late in life, some people would say, as a default, but I don't believe so. I believe I was ultimately meant to be a nurse. I have been at Community Hospital since 1988, and all of that time has been in the ICU. Over that period of time, I've come to see my patients, their families, and my peers as an extended family. I have held the hand of people who are dying so they don't die alone. I have comforted families who have to endure the intolerable pain of losing somebody that they love. I have raged at inequities. And why do I do that? Because I believe that I make a difference. I believe my peers make a difference. I believe that we need to maintain the integrity and the principles that brought me to Community. When I started at Community in 1988, the philosophy that they expounded were the values that I was raised with: integrity, honesty, paying forward, caring for your neighbors. And in light of that, I believe that it is not in the best interest of my patients, their families, or the community to be swallowed up by a large hospital. Now, I've heard repeatedly that Dr. McCabe is a straight shooter, and I have no reason not to believe that. However, I do think that it is in everyone's best interest to maintain Community as it is, to allow us the prospect and the ability to increase our knowledge base, to increase our patient population, and to let us return to the community what they have given us.
Next, I call on, and this is a maybe, Sue Hammond. that's all we had signed up. I want to make sure we've given everyone an opportunity who wishes to speak before the question and answer period. So if there's anyone else that would like to, yes?
Hi, I'm Rod McLean. Some of us have community hospital in our blood. I got it from my father, who spent most of his career practicing obstetrics at community hospital. He's 90 years old, so most of you folks probably don't remember him. I remember when Chris Losner moved in up the street, and her father, John Brown, was the first administrator of community hospital when it was being built in the 60s. Community has always been a source of great pride. When it was first built, it was the cutting-edge hospital in this city, offering a kind of care that no other hospital in the city was able to provide. None of us want to see that go away. I'm a member of the board of directors, and I just want all of you to know that the hours, the days, the months that the board and Tom Quinn have spent over the past 4 or 5 years trying to figure out a way to meet the inevitable consequences of a 4-hospital city that really didn't need 4 full hospitals. It's an awful gut-wrenching opportunity. I know how scared you guys are. I don't blame you. And we all share that concern. And it's why the board, the administrators of community, have found such great comfort in the relationship that's building between Dr. McCabe, University Hospital, the staff, the physicians. There is here a shared mission, a tremendous amount of trust. Nobody can promise what's going to happen in the future. But the one thing that we do know is the community hospital can't continue to exist as the hospital, the freestanding private hospital that we all want it to. It's just a reality of life. The numbers don't add up. So what's the next best solution? The next best solution is to find the best partner for community that we possibly can, and to find people who we trust, and to do the best that we can do to maintain the kind of care, the kind of family atmosphere and relationship that all of you cherish and that we all cherish. And nothing in life is perfect, but this is, we think, is a tremendous opportunity for all the employees of Community Hospital to continue doing what you feel so proud of in an organization that the community as a whole can feel proud of. Thank you.
Thank people for their public comment, and we're going to allow about 20 minutes of question and discussion time, and I believe the first question goes to Ed. After that, after this question, we'll raise our hand and we'll get a mic to you. I don't know if we need a mic in here. Let you come forward. Let's come forward to the podium. That way everybody can see you. That's okay. So people asking questions, I think we better, based on the room, that they come to the podium.
All right, I was not exactly dressed for podium speaking here. I only found out about this about half an hour ago, actually, this meeting. I just had a question. I recognize some people here. I worked there for about 23 years and retired a few years ago. And I don't know if this issue's been addressed, but I was just curious as to how, what's going to happen to the people who have retired from Community General? Are their pension benefits guaranteed? The ones who, those of us, and there are quite a number of us out here in the community, worked there for decades, retired under a, guaranteed benefit pension, not a 401k plan, but a guaranteed benefit pension. So how is, what's going to happen to our pensions under this merger?
Can you hear me? Dr. Hammond, nothing should happen to the pension. It should continue as it is. You may not be aware, but we have a joint website with a lot of questions that answer technical questions like that. It's called CGH- upstate.org. And that specific question is addressed on there, but we do not expect anything to happen to your pension. It will continue as it is. I'm in the same pension plan you are.
Well, no, I mean, you use an interesting phrase, we do not expect. I mean, that's a little,
The pension will continue.
okay.
Thank you for your question. We've had the
Okay, okay, will we be getting that guarantee in writing?
Thank you. Next question?
I'll just raise one here. And earlier on, I was aware that you had applied for a grant, some type of additional funding to help this process move along. Was there a submission or a grant of some kind? And is there any status if there was such a submission?
The grant you may be referring to, there was earlier in the year a joint grant application by Community General Upstate and Van Dyne for HEAL money as part of the HEAL 20 application, and that grant did not get funded. So there isn't a current grant application that's out there for dollars for this initiative.
Yes.
Hi, my name is Doug Tucker. I'm a physician. I actually trained at University Hospital and back in the 80s and worked as an attending at community for 15 years. So I guess this is all sort of near and dear to me also. Presently, I work for an insurance company, MVP Healthcare, and a couple of things that I've heard during the speaking caused a little bit of concern. First, in the presentation regarding the merger was that both institutions would be under one tax ID number. And then I also heard speaking about the relative cost of the two facilities. Unfortunately, the way insurance companies contract with hospitals, this may make a big difference in how much premiums patients pay for their health insurance, and also what individuals pay when they go pay for their care. A lot of people now are buying high deductible health plans, which would make them responsible for the first $10,000 or $15,000 of their own cost. And when you look at a tertiary care facility versus a community hospital, there's a big difference in what the costs are. So that what scares me is that is there going to be a homogenization of the cost where folks that go to the community will suddenly pay university prices. That will be potentially catastrophic on premium costs in the community and also on individual costs that have high deductible health plans. So I wonder if the board has a response to that.
I mean, I think it is one of the issues that you raise is one that has been and is being looked at, and there are differences, as you point out, between reimbursement rates in both institutions. To simply homogenize those and to make the community general hospital patient pay more makes no sense, and there have to be some efficiencies that are built into any sort of relationship, and so certainly that one of the intents of that is to create a more efficient and larger cost structure.
Further questions? Tim, do you have a question? Oh, excuse me. Bruce?
Is it anticipated that there's going to be any surplus money out of the acquisition that might go into a foundation for the benefit of the community? I mean, if there's a sale and an acquisition, something happens to the proceeds. If the proceeds are greater than the liabilities, there should be something left over for some sort of a community foundation. Is that contemplated in this transaction?
I'm not sure I'm wired, but the answer is no. We expect to zero out the balance sheet at the end of the day.
With the possible exception of the Community General Foundation, which may be left intact with some dollars behind to take care of whatever runoff kind of liabilities there might be. And so dollars left after some defined period there might constitute something like you say, but it's not, we've turned over all the rocks and Tom's not hiding millions of dollars last time we checked, right, Tom? So.
Further questions? One question. Then, do you have a question?
One question, the Health Systems Agency has had a longstanding interest in what the future hospital will look like, the hospital of the future. And short of an asset acquisition, when you outline, Dr. McCabe, the benefits of the asset or merger or acquisition, could you see those applying to other hospitals as well? As I said, short of an acquisition, but strengthen clinical linkages, perhaps use of hospital beds in other institutions. And related to that, I asked that question because with the growth that's anticipated for the community, or for Upstate rather, what impact will that have on other hospitals, not just in Onondaga County, but throughout the region?
Well, Tim, I guess I'd say a couple things. One, you know, there are, as you know, we looked in, this is about Onondaga County, but if you go, you don't have to go very far to see other hospitals that are in similar conditions and worried about their future because care has shifted and they're worried about accountable care organizations. You can go to Hamilton, you can go to Auburn, and both of those institutions have concerns as well to variable degrees. I think big systems, whether it's here or in other cities, tend to have lots of different kinds of relationships. You know, it may be as simple as helping to recruit specialists into a community. It might be helping to share the IT expertise so they get to meaningful use and can get dollars. It may be full asset acquisition. So I think over time you're going to see that more widespread, not by us necessarily, but if you look across the broad region, the old system of, you know, I don't know, Ron probably knows how many hospitals were in New York State at one time and how fewer there are today and how probably fewer there'll be in 10 years. The other thing to remember is we focused on kind of the hospital inpatient side, but there is a whole growing, you know, movement out of the hospital too, because much of care is in the outpatient setting, it's in clinics, it's in physicians' offices, it's in primary care, and so that's part of the solution as well. Does that help?
There are no further questions. We're going to move into the next portion of our agenda, and that calls for to outline what steps we will be taking and the project monitoring. Excuse me. Before we do that, though, I'd like to ask Dr. McCabe and Tom Quinn if they'd like to briefly wrap up any positions, anything you need to tie up before we go into next steps.
Just a couple things. First, a comment. I truly appreciate the comments. I think the comments are real. They come from people's hearts and souls and people who have, put their labors of love into the institution. And so I very much appreciate that. And Tom and I both take the dialogue very seriously. It's personal for me, too. My first son was born at Community General Hospital. And I've told people that the first patient I ever did a history and physical exam on was at Community General Hospital as a medical student. So I actually have a little bit of history there as well. A lot of people say to me, well, these are two different cultures. And I'll just make the comment that they are. But I'll also say, as Tom and I walk the halls from time to time, or I run through the ER, I actually think the cultures are more similar than they are dissimilar. I think both institutions are good people, professionals, who come to work every day to take care of patients and do the very best they can. And actually, if we can start with that culture, I think some of the other culture differences go away. It has never been our intent, and it will never be our intent, to create University Hospital West. Okay? Doesn't make any sense. They're different institutions, the missions are different, the patient populations are different. It makes no sense for me to put a Gamma knife up on the hill when I have a Gamma knife downtown, okay, as an example. The cost issue is a real one, and you raise it. Art and I have had that conversation too. And we are higher cost. There's no question about that. Why are we higher cost? Lots of reasons. We take care of some really sick people. There used to be 3 hospitals in this town that took care of trauma patients. There's now 1 hospital that takes care of trauma patients. There are some money-losing kinds of enterprises that used to be done elsewhere that are now done where we are. You used to be able to go to the emergency room anywhere in this city with a nosebleed, and they'd have an ENT physician on call who'd come see you. In at least half the hospitals, I would say, that's a more rare event. So where do they go? They come to us. So there's a long list of reasons. And certainly helping to spread some of the costs and create some efficiencies will help us. And lastly, I just want to touch on a couple of the labor things. You know, as I said at the beginning, it's an unfolding story, so I don't have a full answer for you yet. But I can tell you with certainty that as we've looked at the models, and we're still modeling out the costs and the benefits and what it means practically at the bedside, in Albany, on the balance sheet, the model that we're looking at and modeling out for public employment of the community general hospital workforce starts with the premise that people's seniority will be recognized, starts with the premise that the pension that people have grown to accumulate there will be preserved, starts with the premise that people's PTO, their paid time off, moves over with them, okay? Now, can I promise you all those things? No, I can't promise you all those things, but you saw a slide that said we're going to be fair-minded. And those are the components starting the conversation for me in Albany, with the DOH, with the Attorney General's office, with the GOER, with SUNY. And so I would just ask you to please be careful and bear with us, and don't rush to a conclusion before we get there, okay? It's going to take a little bit more time still, but I want you to know that some of the things that you've said, I don't want you losing 30 years of seniority and not being able to take care of grandkids either, so, okay? So we got to work together a little bit longer. With that, I'll stop and thank you all for coming.